What was point number? How many?
108.
508.
108, sir.
108. Okay. Good evening to everyone and welcome to today's wonderful evening. Suresh? Hematology, we have reviewed anemias, thalassemias, and where do you find a low reticulocyte index in anemia? Which type of anemia? Huh? Megaloblastic? Sideroblastic? Iron deficiency or in aplastic anemia. But if you have a high reticulocyte index with anemia, what is the type of anemia? That means bone marrow is compensating for a peripheral destruction. Hemolytic anemia. The moment the patient has an anemia and you have seen the complete blood picture, when the reticulocyte count is brisk, then you should suspect the hemolytic anemia is what you need to remember. Good to see Sai Krishna Reddy, who correctly answered hemolytic, SMH, and many more who are all online. So, doctor, what is the stain used in Prussian blue for sideroblastic anemia? One more stain starting with letter P for staining iron in bone marrow. Pearl stain is the one which is used. All right. Now, normocytic, normochromic anemias are classified into mainly two types. So, normocytic, normochromic anemias, they are being divided into non-hemolytic. Oh, I'm sorry. You're not telling me? Yeah. Into non-hemolytic and hemolytic anemias. Which ones? Normochromic, normocytic. When do you call macrocytic MCV more than 100? MCV less than 100 is, how much is microcytic? Less than 80. Very good. So normochromic, normocytic are divided into non-hemolytic and hemolytic. Hemolytic are in turn divided into those which have an intrinsic defect in RBC or extrinsic defect in RBC, which is all fundamentally one way of dividing, whether the problem is inside the RBC or outside the RBC. Another way to divide is whether the destruction of RBC is occurring inside the vessel, intravascular, or in the spleen. Then it is called extravascular. Now, anytime, doctor, whenever hemolytic anemia is there in your patient, what is the classical biochemical report that you get? How do you know that this patient in whom you are suspecting is having hemolysis? Increased LDH, increased reti count, unconjugated bilirubin, pigmented gallstones. These are the important indication to say. And is there any obstruction for all this bilirubin to enter from the liver into the gut for in the hemolytic anemia? No. That's the reason all the bilirubin will enter into gut. There it is converted into urobilinogen. Urobilinogen can enter into urine. So that is the reason urobilinogen in urine means no obstruction, which is typically seen in hemolytic anemias. Once more summarize, tomorrow's NEETPG exam, they will give you a clinical vignette, a patient's biochemical report. High LDH, high reti count, unconjugated bilirubin, pigmented gallstones, high urobilinogen in urine. In spite of that, if your heart is not thinking hemolytic anemia, you are too far. Okay? So please remember, clinically, day in and day out, we practice all these fundamentals, doctor. Very good to see 19 online classmates. Now, whenever there is an intravascular hemolysis, how many times, Lawrence? One is inside vessel intravascular, other is? Where is it in? Spleen. Good. Whenever intravascular hemolysis is happening, the hemoglobin which is released by the destruction of RBC goes and binds with a protein in the plasma called haptoglobin. So the haptoglobin gets consumed. And that is the reason intravascular hemolysis is characterized by decrease in haptoglobin, is what you need to remember. Then we discussed earlier about microangiopathic hemolytic anemia, no? What is meant by microangiopathic hemolytic anemia? 2 conditions, 3 conditions that come to your mind. Come on. 2 conditions at least. Microangiopathic hemolytic anemia. In the micro vessels, when the platelet-rich clotting factor not containing clots are forming and the RBC is passing through that, it becomes squeezed, broken, and that leads to helmet cell, which is also called cystocyte. What is that condition? Boy, it's an end of spectrum. One end of the spectrum, you are having hemolytic uremic syndrome. Other end of the spectrum, you have thrombotic thrombocytopenic purpura. We discussed now. All right? Did we or not, Girija? No, sir. In your last year, last before year, 23 years before you discussed, not when after I am born, sir. Huh? Okay. Anyway, now you know. No. 2 types are called microangiopathic hemolytic anemias. What are they? TTP, thrombotic thrombocytopenic purpura. Purpura is there due to thrombocytopenia, and the thrombocytopenia is occurring because all the platelets are sequestered into a clot which is forming inside small capillaries. All right? So there you find cystocytes. Similarly, intravascular hemolysis, when the RBC breaks inside the blood vessel, it is releasing the hemoglobin, and that hemoglobin straight going to kidney and getting entering into urine. So hemoglobinuria, hemosiderin, urobilinogen in the urine, they're all the features of intravascular hemolysis. Let me tell you once more, doctor. Hemolytic anemia is the favorite question. Very good. SMS and Satyendra are rocking by answering it as TTP and HUS. Right? Good. Once upon a time, we were pioneers in online classes. Way back in 2010, Usmania Medical College students, MBBS 3rd year, 4th year used to sit. Online, all my Kaurava Sainyam used to sit, Pandava Sainyam used to sit in the class. Third year, fourth year guys used to rock the answers. Online students who are preparing for entrance used to feel, third year, fourth year, Usmania Gandhi Boreto, chaku, knife, powerful knives. Now our online students are like that. So, doctor, let's come. I mean, even our offline are like that. Don't worry, Girija. Huh? So, this is what, doctor? Helmet cell. Will recognize this? Right? Cystocyte. I want to ask one of the postgraduates to mentor the students in the WhatsApp group. So I'll give him notes. He keep punching the questions and you keep answering of the completed classes. I think that is the best way to do the revision. What do you say, Teja? WhatsApp coaching. Right? What is the app you are following for coaching? WhatsApp. So, now doctor, hemoglobin gets broken down, from that hemoglobin is released and that will enter into urine and that become hemosideриnuria, hemoglobinuria will enter and it will typically be consumed attached with the haptoglobin. That's the reason haptoglobin levels will come down. We attach it to haptoglobin, it will come to liver and go to gut and that lead to urobilinogenuria. Urobilinogen positive in urine. If there is any obstruction like obstructive jaundice, you will not find fecal urobilinogen. That is the difference. So what lead to intravascular hemolysis? Any mechanical hemolysis, like you have placed a prosthetic valve. Tomorrow after doing surgery to the patient, you placed a mitral valve, aortic valve. Then when blood is passing, RBC will be broken down by that. That lead to hemolysis. Where is it happening? Inside the vessel. Paroxysmal nocturnal hemoglobinuria. This you remember at least? What is paroxysmal nocturnal hemoglobinuria? We are going to come discuss that. Then microangiopathic hemolytic anemia. All these three will lead to intravascular hemolysis. So, doctor, this is the RBC, which is broken down intravascular, leading to cystocytes, and the hemoglobin is released, that is binding with the haptoglobin, and that is going to the liver, and from the liver it will enter into the gut, convert into urobilinogen. That is one method. Or in the liver, and also when the RBCs are broken, the iron released, that will come and consumed by spleen and liver. Then the hemoglobin become heme become hemopexin complex and also enter to liver. Then heme can bind with albumin and enter into circulation. These are all the various things that can happen with intravascular hemolysis. Similarly, whenever you place a prosthetic valve, that can also lead to the development of hemolytic intravascular hemolysis. So broadly, hemolysis is divided into intravascular hemolysis and extravascular hemolysis. Intravascular hemolysis typically when the RBC is broken inside the blood vessel. And extravascular means typically the RBC is laid with this immunoglobulin G, and when it is passing through the spleen, the splenic macrophages, Kupffer cells are there, no? They identify the immunoglobulin G laid on the RBC and break it down. That is extravascular hemolysis which occur in spleen. Coming to extravascular hemolysis, what will you remember, doctor? It is the macrophages in the spleen which are slaughtering the RBCs is what you need to remember. Master MBBS is saying WhatsApp can be used very innovatively, actually, right? So I'm going to ask some of our postgraduates who are toppers earlier. Some students are very extrovert. Some are very introvert. Me and Girija are extroverts, correct? If you answer In WhatsApp, you are extrovert. Some people will run away from, Amma, na valla kadra babu. ఈ నిమిషానికి ఒక క్వశ్చన్ అడుగుతుంటే నేను ఎక్కడ సావాలని చెప్పి వాట్సాప్ మీద పారిపోతుంటారు. సో yesterday, Sunday, after our mock test is over, suddenly around 130 students came and joined WhatsApp group. Of course, 20 people ran away, unable to bear our midnight 3 o'clock masala beating also. Right? So, but I'm enjoying interacting with the students on the WhatsApp while I myself is preparing across the day. Notes, PowerPoint. My life has become like a desk job. But I want to do that for all of you because by November ending, we should be ready with 1500 pages. The notes that you don't revise is useless, doctor. Remember, the things that you study are useless. And if somebody gives you 1000 hours video, 2000 hours video, you can never be able to revise that. If you have 6 months time, ideally you should have 6 months time to hit the exam, serious candidate. Maximum 500 hours of discussion, in which we should finish the 45,000, 54,000 points. Parallelly, you must be mixi mein dalo aur rubbute jao. Now tell me, doctor, what are the 4 bone marrow failure syndromes? DC, BD, DS, TAR, FA. Come on, at least tell the full forms. Schwanman diamond, Blackfan diamond, Fanconi anemia. What thrombo? Come on, thrombocytopenia and absent radius and diskeratosis congenita. Keep on revising. So, extravascular hemolysis occur in the macrophages in the spleen. It leads to splenomegaly. And what do you find if spleen is eating the RBCs? Spherocytes will be found. Suppose if it is a hereditary spherocytosis, even hereditary spherocytosis lead to lot of extravascular hemolysis inside the spleen. When the baby is born itself, he will have a splenomegaly in hereditary spherocytosis. Right? And all his RBCs are getting broken down. And all that breaking down of the RBCs will lead to hyperbilirubinemia. And that hyperbilirubinemia all that bilirubin is going to liver. In the liver, all that excess bilirubin is precipitated in the gallbladder. That's the reason the baby of hereditary spherocytosis will be born with massive splenomegaly along with the stones in the gallbladder. That's the reason only splenectomy is not enough in hereditary spherocytosis. You need to do splenectomy plus cholecystectomy. Together you need to do in hereditary spherocytosis. Now tell me, hereditary spherocytosis is because of which protein deficiency? నిన్న చెప్పిన పాట ఇవాళ మర్చిపోతే ఎట్లా గిరిజా? Have you seen that movie called Postal? Jab chatur nari, jab chatur nari. Very famous Mahmood movie. So I became a music teacher for you, and you are forgetting yesterday's Sarigama Padanisa. Spectrin, ankyrin deficiency. Do you remember we have discussed elliptocytosis? Okay. This, if you don't tell, we will cancel the class, Girija. Pseudo gout. What are those crystals made up of? Nobody, only Girija. Pseudo gout is by which crystals, dash crystals. Chalo, baileram. Enduku sadhu upayogam ledhu? Come on. Girja. CA. Anybody want to tell? Very good. Calcium pyrophosphate crystals. And gout is due to uric acid crystals. What is that xanthine oxidase inhibitor used in gout called? Xanthine oxidase inhibitor. 2 drugs. What is that? దూరబంధు పేరు గుర్తు చేసుకుంటే ఎట్లా అమ్మా? మురళీరెడ్డి మామ ఎక్కడో కలిసిన నేను. Come on, doctor. Allopurinol, febuxostat. What are they? They're all xanthine oxidase inhibitors, no? Rusburicase. You remember? Read back the gout, which we finished the discussion. What are you doing the whole day morning? I'm becoming a tough mathematics teacher. A good teacher inspires, a bad teacher conspires, worst teacher complains. Right? So, read, doctor. The train need to catch the speed. Early morning, hot cup of tea. Notes is there before you. Fatafat revision karte jana. Right? Very good. Satyendra Alluru already said febuxostat. Master Dinesh said Rusburicase. And Tarun Agarwal. Acha monochin Taruna? Same Tarun? Oh, Agarwal hai kya? Acha. Tarun Agarwal said allopurinol. Sai Krishna Reddy dumped. Colchicine, he said. Colchicine is not a xanthine oxidase inhibitor. Sai Krishna Reddy. So, all right. I mean, am I intimidating you? No. Why are you so looking dull? Energy. Why ek Horlicks mango, Bornavida mango, magar energy ke saath padhai karo. That's very important. Forgetting is natural because that's how we are born, right? Otherwise, so many girls said no to us and slapped and thrown us out. We never remember them. How many they are? So, now, what is the difference between extra and intravascular hemolysis? Favorite question of examiner. No hemoglobin urea. No hemosiderin. Hemoglobin, hemosiderin enter into the urine after the breakdown of the RBC only if it is intravascular, not extravascular, is what you need to remember. But even extravascular hemolysis also can lead to urobilinogen in urine. वो तो है. Because even extravascular spleen also will forward that bilirubin to liver. Liver will forward it to gut, and the gut will convert that into urobilinogen, and you can find urobilinogenuria not only intravascular but also in extravascular hemolysis is what you need to remember. So, doctor, have a clear mind picture. Intravascular hemolysis, extravascular hemolysis. In intravascular hemolysis, after the lysis is there, hemoglobin is released from the kidney, it becomes hemoglobinuria. In extravascular hemolysis, after the breakdown, the globin and heme are being separated. Unconjugated bilirubin is created that will go to the liver, and from the liver, it will go into the bile and excrete as fecal stercobilinogen and absorbed into blood and go to kidney and come out as urobilinuria. Urobilinogen in the urine is feature of both intravascular and also extravascular. Now coming to two conditions which are normocytic anemias but not hemolytic. You need to remember. Anemia of chronic disease. Which chronic diseases lead to anemia of chronic disease? Rheumatoid arthritis, SLE, all these autoimmune conditions. And other is aplastic anemia. Now I will ask you a question. Today, Tough day, Girija. Only you are my target today. See, aplastic anemia, how is the bone marrow? Bone marrow is all fatty. Aplastic anemia will lead to pancytopenia. In which condition pancytopenia will be there with a normal bone marrow? Two conditions. Bone marrow is normal, but still you got pancytopenia. Still you got pancytopenia. Where? శనివారం అడిగినా శుక్రవారం అడిగినా ఇదే క్వశ్చన్ దొరసని ఎట్లా నువ్వు గట్లా ఆన్సర్ తప్పు పెడితే కమాన్ టూ కండిషన్స్ whenever there is any hypersplenism with splenomegaly. Second, come on, notebook movie. You remember that winter, that summer? Come on, Girija. Come on. Whenever anti-thromboplatelet, anti-RBC, anti-WBC antibodies, all the three antibodies, Yvonne syndrome we discussed, where both platelet and RBC antibodies are produced. Which rheumatological disorder may all the three antibodies are produced, they break the RBCs and lead to pancytopenia, and the bone marrow is still normal. Correct. Tell loudly. That is Girija. What will you remember? What are the two conditions where bone marrow is normal? Pancytopenia is there. SLE, hypersplenism. And what are the conditions where pancytopenia is there with a abnormal bone marrow? Aplastic anemia, myelodysplastic syndrome, myelofibrosis. In all these conditions, bone marrow is abnormal and leading to pancytopenia. Okay? Pakka? Good. No problem. Now comes anemia of chronic disease. 4 points you need to know, doctor. If you are scratched before exam also, you must talk. Is my speed okay? Or am I going slow? This speed only we are forgetting. If I go too fast, you won't. Now, any inflammation, whenever inflammation is there, that causes increase of interleukin 6. That will increase the hepcidin. And hepcidin is produced by whom? Hep means liver. And there's no rocket science about it. Hepcidin is liver. Liver causes increased release of hepcidin. Hepcidin will bind with ferroportin. Where is ferroportin? On the intestine, you have ferroportin. So ferroportin, which is there on the intestinal mucosal cells and macrophages, and that inhibits the iron absorption. Due to that, there is a decreased release of iron from macrophages and decreased absorption of the iron from the gut, because ferroportin is there in both the macrophages and also on the intestinal mucosa. Both the places you are having ferroportin. So chronic inflammation lead to increased which interleukin? 6. That lead to increased production by liver? Hepcidin. High hepcidin will cause diminished ferroportin. Where is the ferroportin present? Intestinal mucosa and macrophages. And because of that ferroportin blocking by the hepcidin, what will happen? Macrophages don't release the iron into the serum. Intestine doesn't absorb the iron. That is the reason serum iron become low in anemia of chronic disease. Now, Girija, what is the single laboratory measure that differentiates iron deficiency anemia from anemia of chronic disease? Ferritin. And what happens to ferritin in iron deficiency? And what happens to ferritin in anemia of chronic disease? Beautiful. Very good. So decreased iron, increased ferritin, How about TIBC? Total iron binding capacity decreases. Then, whereas in iron deficiency anemia, TIBC increases. Okay? Now, normocytic anemia is to start with, or a period of time when the iron is in the serum is becoming very, very low, then it also becomes like iron deficiency, microcytic anemia. So, anemia of chronic disease can be normocytic, anemia of chronic disease can also be microcytic. So, how do you treat anemia of chronic disease? You address the underlying cause of inflammation. Treat rheumatoid arthritis, treat SLE, treat Sjogren's. Then, whenever there is an anemia in a rheumatoid arthritis patient, don't jump. See, all other coaching programs cannot improve your iron, but I can improve the iron. Bolke, unko transfusion dete gaye to. Without treating her inflammation, which is the underlying cause, all the transfusion you have given will lead to iron overloading state. And she will die. Understand? So that is the reason. Don't give blood transfusion judiciously in cases of anemia of chronic disease. While preparing for entrance exam also, use video libraries judiciously. Don't overload with transfusion. You will end up in iron overload and don't remember anything. Everything is heavily loaded. Right, doctor? See, to get seat in NEET UG exam, people go to Kota, Akash, Pikash and all that, no? All questions, if it is MSET in Andhra Pradesh, come from Telugu Academy book. Adokkade chadivite chalu. 2 biology, 2 physics, 2 chemistry, khatam. If you want to crack national NEET UG exam, NCERT 11, 12, physics, chemistry, biology. Bas, that's all. Only 6 books you need to read. Not even a single question will come out of that. Now I am studying with my younger son. Next 5 years he is going to get into medical college. He is in 8th class. Basic NCERT. Similarly, when you prepare for entrance exam, all these coaching centers, what they will do? First, they will all start with a simple program of 200 or 300 hours or a simple question bank of 10,000 or 20,000 questions. Next year, they need to give something new, no? So they keep adding. Ultimately, it becomes swollen to 800 hours, 900 hours. They'll tell, our question bank is 100% strike rate. But who has time to go through all your question bank and all your videos? Nobody will have time. That's the reason. What is best, Kulsum? East or West? Murali Bharadwaz sir notes is the best. Understand? इसमें याद रखने के लिए ही दिमाग खराब हो रहे, बेजार निकल जा रहे. ऊपर से बड़ा बड़ा बुक का 19 बुक का कहाँ पढ़ते बेटा? So keep revising, doctor. How many you should tomorrow take the notes that I have given, finish 30 pages revision before coming to class, and tell on the WhatsApp that, sir, I finished today 30 pages in one day. First 30 pages in the notes that I have given, no, tomorrow I will ask questions before starting class. Per day 30 pages, your capacity should increase to per day 100. Okay, we'll keep per day 220. Deal? Videos are already there. And anything that you feel doubt, I want more understanding, go to video. Otherwise, directly from the notes I have given, batti maro. आप आए तो मैं टेस्ट करता हूं. पहला 20 pages per day of the completed notes. Already I gave you some 500, 600 pages. De diya na? So slowly you increase your capacity to 60 pages, 100 pages per day. Then 15 days you are finishing one round. Slowly you increase your capacity, 200 pages per day. 1 week you are finishing. That should be the ultimate goal. समझ में है ना? और फर्स्ट 20 पेजेस कार्डियोलॉजी से शुरू होता. कुछ डाउट है तो पूछो. वो वीडियोस भी है, मुरली भरद्वाज का आत्मा भी है. आत्मा से समझ में नहीं आ रहे तो परमात्मा को पूछो. राइट? हाँ. बट रिवाइज फ्रॉम डे 1 you start revising kindly. Okay? Now, anemia of chronic disease is normocytic. Normocytic. But it can become microcytic. All right? Now, one important condition which is chronic inflammatory state is a chronic kidney disease. All diabetic nephropathy, CKD patients of the nephrologists are all carrying a chronic inflammation. They will all develop anemia of chronic disease also. In that case, you can give erythropoietin injection. So what is the main bread and butter of a nephrologist? How he will go to Switzerland for vacation with his sweetheart? Erythropoietin company guy will sponsor that, right? So, but before giving erythropoietin, you need to check. You need to also give iron injection, because only erythropoietin with no iron is no use, right? Now, doctor, let us once more get a mental picture of what all that we discussed. Dietary iron accumulates. There is a ferroportin which will make it to come into plasma, and that is possible if the hepcidin is not expressed. Normally, normal hepcidin, it will come. But if there is anemia of chronic disease, what will happen? Typically, hepcidin overexpression will be there, and it will go and prevent the iron absorption from the ferroportin. Whereas in hemosiderosis, hemochromatosis, the hepcidin expression is suppressed in the liver. Nobody to stop the ferroportin to absorb iron, and that lead to a lot of iron absorption. Got it? So you need to remember one thing, doctor. If you are having an iron deficiency anemia patient, even in him also hepcidin expression is low. That's the reason the moment you start iron therapy in an iron deficiency patient, initially hemoglobin will drastically improve, because the absorption is very high, because their hepcidin levels in iron deficiency are reduced, and that lead to ferroportin hungry, waiting for the iron to be given by you. The moment you give it, it will all absorb it, and then it will be consumed. Right? But later on, over a period of time, as the hemoglobin value is recovering, iron absorption will not be that fast as what it is initially in a iron deficiency anemia patient. Tomorrow, as a gynecologist, your main friend is iron therapy. You need to be authority in the entire kernel. No kernel gynecologist obstetrician knows about general medicine as good as Girija, because Girija's dad is a top physician, right? Whose daughter is Girija? Correct? Girija? So, and always remember, a gynecologist obstetrician who knows a lot of general medicine is a top gynecologist obstetrician. Because if you know general medicine well, you know physiology well, you know endocrinology well, and all endocrine problems of women who don't need knife. That is a cold gynecology. Hot gynecology is all cutting. Okay? Of course, there are only two things to cut there. So now, doctor, this is what? Liver, enterocyte, ferroportin. Whenever inflammation is there, the hepcidin levels are increased. They will typically block the ferroportin level. Once more, to get an idea psychologically, I have once more posted a lot of other images. So once more here, Dr. Anemia of chronic disease, blocked iron release from the macrophages, decreased iron uptake, and that lead to anemia. Any hemochromatosis, decreased hepcidin production will cause increased ferroportin expression, leading to increased iron, is what you need to understand. So, always when you clinically approach the patient, E is it IDA, E is it ACD? IDA versus ACD is a big imbroglio that you need to understand what is there in my patient. When the hemoglobin is less than 13 in males or less than 12 in females, you need to look for other biochemical things like ferritin and all. Also look for inflammation. Look how is the transferrin saturation. If the transferrin saturation is less than 16%, transferrin saturation, look how is the ferritin. Is the ferritin normal, ferritin reduced, ferritin increased? Ferritin reduced means वो सीधा iron deficiency anemia का केस है, उसमें टेंशन नहीं है. But if the ferritin is increased, straight away case that it is a anemia of chronic inflammation. Problem will come if they are both are coexistent. Like a rheumatoid arthritis patient has an ACD and also she is not eating food and she also has got a iron deficiency, let us assume. So then what will you do? You will do the serum transferrin receptor level divided by logarithm of the ferritin ratio. Or you can do the hepcidin levels. If the hepcidin is normal, then that is combination. But if the hepcidin level is raised or the serum transferrin receptor and ferritin ratio is low, then that is anemia of chronic disease. Anemia of chronic disease identified by the presence of the low increased hepcidin and a low ferroportin. That's how you need to remember. So, doctor, hepcidin level, transferrin saturation, ferritin, and soluble transferrin receptor. With that, you will be able to reach a conclusion. And let me tell you once more, NEETPG में मैं स्टैम्प पेपर के ऊपर अपना अंगूठा छाप मार के बोल रहा हूं, डेफिनेटली आने वाला क्वेश्चन है. And out of 2 lakh people preparing for entrance who are having all the mobile apps for NEETPG preparation in the world, even if they have it, out of 2 lakh people who understood this concept will be hardly 25 to 30,000. That means you eliminated with one shot, red coin aa gaya carrom board mein. You are going to win, right? So every day before sleeping, I play at least 2 to 3 games of carrom board and go to sleep. That has become a addiction in the home. So red coin aa gaya aapko, barabar? You are going to be the winner. Now, anemia of chronic disease, what are the causes? Chronic infection like rheumatoid arthritis. Any neoplastic disorder can cause anemia of chronic disease. Chronic kidney disease can cause. Any chronic autoimmune disease. Achha, chronic infection means TB, osteomyelitis. They're all very chronic infections. Leprosy, all those things. There also you'll get anemia of chronic disease. Then SLE, rheumatoid arthritis are the autoimmune disorders which can lead to anemia of chronic disease. Now, Lawrence, question to you. Lawrence कुछ busy thought में है. Fine, Lawrence? Good. Anemia, only Lawrence will answer, please. Anemia of chronic disease versus iron deficiency anemia. How is serum iron level in IDA? Low or high? Very good. And how in Higher, 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 low. Then how is ferritin? ఇప్పుడే కదా మనం just now we discussed no anemia of chronic disease lead to increased hepcidin, that lead to decreased ferroportin, that will decrease the iron absorption, that is the reason serum iron is low. అదే చెప్పుకున్నా కదా లారెన్స్. ఎట్లా లారెన్స్ నువ్వు ఏదో ఉల్జన్లో ఉన్నావు లారెన్స్. గర్ల్ ఫ్రెండ్ is broken up in the WhatsApp. No problem, she will be available in the Telegram. You can catch her over there, right? Just now we discussed now, Lawrence. Face to face class only this much confusion hai, to video mein kya samjhoge? I should thank you all people, because if you didn't understand, nobody will understand. You understood? Everyone understands. Simple. You are helping me to become a better teacher, better video to be produced than all those studio-based videos which are being produced by the national authors of the books who copycatted from all the other books, right? That's the reason this year I am personally authoring 1,500 pages. I am going to write NEETPG, so I am a topper and also author, so I can give a fitting competition to my competitors. On the top of it, I am going to be classmate to Girija in MD Gynecology and Obstetrics. Then I will hold my pant like this and walk. If there is anybody wash, we used to have a joke on male MD Gynecology Obstetrics. If they are coming and ward lady is cleaning the ward, no, they will make their pant lifted up and then walk on the side. Oh, please don't. But some of the best gynecologists, obstetricians are all men. Now, doctor, aplastic anemia. 6 points you need to master. Fundamentally, hematopoietic stem cells are destroyed. That's the reason. What are hematopoietic stem cells? 3 kinds. Erythroblasts, megakaryocytes, and myeloblasts, lymphoblasts, and all the precursors of WBCs. What led to that? Radiation, Epstein-Barr virus, HIV, hepatitis, any of them. Fanconi's anemia is a cause of congenital bone marrow failure syndrome, dyskeratosis congenita, etc. Then it can be immune-mediated. Autoimmunity will go and destroy. Certain drugs, if you give, like benzene, chloramphenicol, a very common drug, can lead to the development of aplastic anemia. Alkylating agents, antimetabolites among the anti-cancer drugs can lead to aplastic anemia. So 2 things happen whenever you have aplastic anemia. How will be the ready count? Decreased. How will be the erythropoietin by the kidney to compensate that? Increased. And what is pancytopenia? Anemia, leukopenia, thrombocytopenia, they're all called pancytopenia. But how will be the type of anemia it is? Is it a microcytic, normocytic? Aplastic anemia? Normocytic. Normocytic, but hypocellular bone marrow with fatty infiltration. Right? Aplastic anemia and anemia of chronic disease. 2 conditions which are what type of anemia? Normocytic, normochromic anemia, runde karanalu. Like a parrot, you have to wake up and answer. Anemia of chronic disease and aplastic anemia. Barabar? Good. Now, what are the symptoms? Fatigue, malaise, pallor, purpura, mucosal bleeding, petechiae infection because there is no WBC. How do you treat? If already patient is on any antiplatelet drug or anything, already his platelets are low due to pancytopenia, why will you give that? You won't give. If he is already on any if that aplastic anemia can be due to autoimmunity, so you can give immunosuppressive drug like anti-thymocyte globulin and cyclosporin you can give. You can do bone marrow allograft. You need to give RBC platelet transfusion. And you can give, now I'm going to tell 2 words. Filgrastim. Filgastrim, sargomastrum. Sargomastrum. Filgastrim. Come on, tell. Sargomastrum. This is GCSF, granulocyte colony stimulating factor. This is granulocyte monocyte colony stimulating. Filgastrim, sargomastrum is the ones which you will give. Once more, I will ask this tongue twister. Filgastrim, sargomastrum. So that is GMCSF. Also, you will administer. So now let us talk about. So you'll remember all these points. No tension इसमें. इनले मैंने बट्टी रट्ट मारने का कुछ है क्या? कुछ भी नहीं है. Kali alkylating agents, benzene, chloramphenicol. You need to remember. And you also need to remember reti count low, EPO high. That's all. Like that you need to decide. If you decide like that, 100 pages, you can revise. First time only 20 pages I am saying. So what points require rattu marne ka? Tattu is there. That you need to identify in the first reading. You'll read and come, right? Tomorrow. We'll start half an hour will be only quiz of the first 20 pages in the notes I have given to you. Then we will start the class. Huh? What is that? That's what they said. Our notes in the you have that notes I have given a total cardiology. So you already have videos of the cardiology. First 20 minutes we'll have a little quick revision. I will only open the book to ask you questions. You won't open the book and you will answer. That is the deal. Okay? Like that, if I am able to push you, then we will. Master Dinesh is saying, sir, are you really attempting NEETPG upcoming 2023? You can write the exam proxy to me, sir. Once upon a time, Baiju Ravindran was there. No? Every year he used to take exam and he is the 99th percentile scorer. That's why it's very popular. Good. No. What I will do is, if I get the seat adjacent to Girija, I will take the NEETPG so that jara copy marenge. Something we should do. Hook by crook, we have to get the seat, right? Same questions will not be there, I think, on the screen, no? To your adjacent guy and you. Okay. So, no problem. We'll develop some sign language. Chromosome 13, like a stock exchange. I keep saying. Chromosome 13 is for what? Retinoblastoma, and secondary tumor is osteosarcoma in that. Codman's triangle? Bubble, so bubble appearance? Not osteosarcoma, only giant cell tumor. Clastoma, which is also called giant cell tumor. Where do you find idi chepparante asalu super? Ready? Pakka. Endomysial inflammation where you find, perimysial inflammation where you find. Come on.
Dermatomyositis is perimysial inflammation, and polymyositis is endomysial.
Polymyositis is endomysial inflammation. Dermatomyositis is perimysial inflammation. Super. Good, One big clap. ఏ మాట కామాటే భూమిరెడ్డి గారు మీరు చదివారంటే అసలు మొత్తం భూకంపం వస్తుంది భూమిరెడ్డి గారు ఇన్ బంజారా హిల్స్. Now, Fanconi anemia. क्यों बेटे कुलसुम क्या सोच रहे हैं? यहाँ पढ़ाई से भी ज्यादा ड्रामा चल रहे हैं. हम तो ड्रामा करते हुए पढ़ाई करेंगे. Autosomal recessive. And what is the problem? There is a defect in the repair of the DNA. What is the cause of Fanconi anemia? Defective DNA repair lead to Fanconi's anemia. Because when the DNA is defective, the WBC, RBC, platelets, their precursors are not produced, that lead to bone marrow failure. So they too will develop normocytosis or macrocytosis on CBC. That is Fanconi's anemia. But what is very interesting about Fanconi is they'll have certain physical features that you need to identify in Fanconi. क्या होता है? Strabismus, squint. Then low set tears, frequent infections, deafness. They also have absent thumb. So absent radii with thrombocytopenia is star syndrome. Here absent thumb and hypopigmentation, freckles can be there. They have aplastic anemia. It is an autosomal recessive disorder. It is a chromosomal breakage. And bone marrow replacement is a treatment. These 5-6 points, like a parrot, you need to remember in the mind. What is Fanconi? If I ask, no, Monica, fadafat you should tell. Strabismus, low set tears, absent thumbs, hypopigmentation, presence of the freckles, autosomal recessive, it's a DNA repair defect, and that lead to normocytic anemia because it lead to aplastic anemia. Now, what are those intrinsic hemolytic anemia? The problem किसके अंदर है? RBC के अंदर है. In this classification, you remember 6 conditions that are intrinsic hemolytic anemias. So, intrinsic hemolytic anemias. So, Master Dinesh is saying, sir, people are craving for toppers interviews, but they are failing to follow people experienced like you, sir. So, what Dinesh want to say is, topper is plus. The guy who is following is minus. Minus into plus, what it will result in? Minus. So, don't follow topper. Right? But I am a big miserable failure. 23 years I have been studying same subject. So I am a minus. So you follow me, minus into minus become plus. There's a great chance. That's what Manish want to tell, right? So intrinsic hemolytic anemia. Hereditary spherocytosis, a problem in the RBC, intrinsic defect. Paroxysmal nocturnal hemoglobin urea is intrinsic defect. G6pd deficiency is intrinsic defect. Pyruvate kinase deficiency is intrinsic inside RBC. Sickle cell anemia, HBC disease, in all these things, it is an intrinsic defect. Next time when I ask you, tell 6 causes of intrinsic hemolytic anemia. You have to tell. Hereditary spherocytosis, PNH, G6pd deficiency, pyruvate kinase deficiency, sickle cell disease, HBC disease. Do. No thinking in exam. Right? Now, 2-3 points about each of them. Then what are extrinsic? Outside RBC. RBC is absolutely fit RBC is going, but it is being attacked by the villains in the street. What are they? Autoimmune hemolytic anemia, microangiopathic hemolytic anemia. It is being crushed while passing through the platelet-rich clotting factor, not having clots formed in the microangiopathic hemolytic anemia in TDP and HUS. Then macroangiopathic hemolytic anemia, prosthetic valve is there, it is passing through the teeth of the prosthetic valve, squeezing to that and it's broken down. That is extrinsic hemolytic anemia. And any infection like a clostridial infection, gram-negative sepsis, they also will destroy the RBCs. The problem is not in the RBC but outside the RBC. Now let us talk about intrinsic defects one by one. Fatafat, 4-5 points. Hereditary spherocytosis is autosomal dominant. Always, how will you remember, Lawrence? Structural protein disorders are all like Marfan syndrome is collagen. Hereditary spherocytosis is a structural protein like ankyrin, band 3, protein 4.2, spectrin. These are all what? the proteins on the surface of the RBC's membrane. So their defect in the RBC membrane skeleton and plasma membrane will lead to hereditary spherocytosis. Similarly, so structural disorders are all autosomal dominant. Rate limiting enzyme disorders, they are all autosomal recessive. Autosomal recessive occur when you are a child. Autosomal dominant will appear when you are in the mid-40s. That's the difference. So tell me, doctor, what are the structural proteins? Anchor in band 3, protein 4.2, spectrin, all of them. And how will be a spherocyte identified? No central pylori is spherocyte. Excessive central pylori is a feature of excessive central pylori. Target cells, beautiful. Good. Yeah, target cells. How just you turn the page and you found there, you written there. Luckily you got it there. Or you looking at that, you remembered. Okay. See, that's the reason what you do, no? The notes I have given, no? Vinayaka Chauthi is coming, no? So you put there, nicely put paspu, so that feel that scent of the turmeric of paspu. Then those points you will remember. In single page, lot of points like sargomastrim, filgastrim, all these things are there. Put more paspu. Wherever those pages which are containing too many of forgettable points, more paspu you put. Vinayaka Chauthi, pray God, God keep Dr. Murali alive. He's in his 49. I am at my 25. So luckily you have sent him. No heart attack in the midnight until November. After that, I will not ask him. Really, also the other day, I was feeling a bit uneasy. So I thought, I made a deal with the God that, God, from tomorrow I will only drink 60 ml Dalmore whiskey, not more than that. Save for myself until November. I finish these 1500 pages notes, then finish 600 hours video. Then I will die, no problem. I'm ready to come back to you. So, but it was all due to the little bit of reflux. That's the only reason. So, decreased surface area will increase because spherocyte has a decreased surface area compared to biconcave disc of a normal RBC. That lead to increased MCHC, and that lead to premature removal of that spherocyte by spleen. That's the reason it is an extravascular hemolysis that you see in. And how will be the haptoglobin levels in extravascular hemolysis? Or intravascular will it decrease? Mainly it will decrease in haptoglobin, decrease in intravascular hemolysis. Extravascular also it happens, but not that characteristic. So doctor, you need to know that if you look at the RBC membrane, you have band 3 protein, ankyrin, spectrin. Then glycophorin, C and D protein, and actin and spectrin. So hereditary spherocytosis means 3 proteins in this. Band 3, protein 4.2, ankyrin, spectrin, 4. Whereas hereditary elliptocytosis means protein 4.1 or spectrin, predominantly alpha spectrin. That is elliptocytosis. That is the major difference between the two. Now, what will you see in hereditary spherocytosis? Splenomegaly. The baby also has pigmented gallstones. Not only splenectomy, you will also do cholecystectomy. Now, question comes to Teja. Teja, what is that virus which love to create a aplastic crisis in all the people who have hemoglobinopathies or hemolytic conditions? Cytomegalo, munna kuda kada answer cheppinu. Epstein-Barr virus. No. Come on. That day, Sai Krishna Reddy answered. Let me check. Sai Krishna Reddy. Yeah. Yes. Yeah. Very good. Parvovirus. Devdas का पारू है ना? Oh, Paru, Parvati, Parvovirus is responsible for aplastic crisis. You should not forget such things. Favorite questions, no? Parvovirus, B19. That's the reason I'm always afraid. When creating the points, no, I will never load you. Because what is most frequently asked only to remember is a big challenge. On the top of it, if I add a fancy notes, no, where will you remember? Impossible. So, but this is short notes. Now, if you look at the laboratory, there is a decreased mean fluorescence of the RBC if you do a test called eosin 5 maleimide binding test. What is that called? Eosin 5 maleimide binding test. If you do, right? That will be abnormal. Then there is an increased fragility, osmotic fragility. The RBCs will become broken down with exposure to hypotonic solution. That's called osmotic fragility. Because if you put in hypotonic solution, there is more water in a hypotonic solution which will enter into RBC. A little enter only, already it is having little space to accommodate, it will be burst. Right? Then they have a decreased MCV or normal MCV. And treatment is splenectomy. So what is this, doctor? This is eosin 5 maleimide test. This is how it looks like. Eosin, this is the control, this is the hereditary serocytosis. Then this is the peripheral blood smear of a patient where you are seeing at the age of 2 days, it is showing spherocytes, crenated RBCs, polychromasia, etc. When the child became 9 months, then spherocytes with the increased, absent central pallor, no? Then this is mother who is showing spherocytosis because it is inherited as a autosomal dominant condition from the mother. So one more, eosin 5 maleimide labeled RBC test in hereditary serocytosis. So how will you revise in the second reading? Hereditary serocytosis, book is there before you. Splenomegaly, gallstone, CMA binding test, osmotic fragility, splenectomy. That's all. Only that bolded areas you should get ready. Then hereditary serocytosis, autosomal dominant, anchorin band 3, protein 4.2, but 4.1 is in erythrocytosis and spectrin. There is a decreased surface area. It is an extravascular hemolysis. Finished. Over. Like this, you should revise. Last moment. Quick. That's how you will revise within 1 minute hereditary serocytosis, 1 minute TNH. Now we'll discuss in detail because जिंदगी में पहले बार हेरिडिटरी सेरोसाइटोसिस से मिल रहा है, उसको सेंट्रल पेलर नहीं रहता है, उसका ऑस्मोटिक फ्रेजिलिटी बहुत रहता है. All these things you are learning first time, taking so much time. On the top of it, we have attention deficit hyperactivity teacher. Right? So we go off track in discussing so much of nonsense. So थोड़ा स्लो चलता, मगर समझ में आ गया ना. तो जाते ही आप क्या करना, सोने के पहले अभी हम 4-5 पेज खत्म किया ना, एक बार क्विकली रिवाइज करके सो जाओ. उठ के कार्डियोलॉजी 20 पेज प्रिपेयर होके आओ. कुछ डाउट है तो वीडियो में देख लेके आओ. राइट? So I will be doing 2 jobs. I'll be doing 2 jobs. One to teach you, and your job is to listen, then to forget, and come to class. Only 3 jobs. Coming to class is predictable. Forgetting is absolutely predictable. Listening क्या है, खाना छोड़ दिए तो टीवी शो चलते रहता. All the 3 are passive, like expression, no inspiration. I am the inspiration. There's a muscular activity required to ventilatory effort. Good. So, doctor, paroxysmal nocturnal hemoglobinuria. Lawrence, what is meant by paroxysmal? See, MBBS first year, you loved a girl for 3 months. She dumped you. Then after that, exams came, you finished. Then once more, second year MBBS, 4 months. Once more, you proposed love, and then you, by the time you understood the girl doesn't like you, that is another 4 months over. Then once more, you prepared. So paroxysmally, we are falling in love, coming out of it, getting down. That's called paroxysmal. Then nocturnal. Night only, there is a RBC breakdown. Night only, urine is red colored. Morning normal, right? ऐसा काइकू होता है बोले तो, if you look at fundamentally the problem is in the bone marrow. Bone marrow is the factory where the RBCs are formed. So when the mummy called bone marrow is cooking the RBCs, it has done a small problem. What did it should do? There is one protein in the RBC membrane. It produced it defectively. So that's the reason this is also called acquired stem cell disorder. What is the name given for it? The disorder is in the stem cell, but it is not congenital. पैदा होते ही नहीं है. Later that got acquired, right? It is an acquired stem cell disorder. Now, what is the disorder that happened? There is a thing called GPI anchor protein. Its synthesis is impaired. And it is an anchor for what? GP means glycoprotein. Glycoprotein 1, anchor synthesis for delay accelerating factor. So delay accelerating factor is called DAF. It is also CD55 is the delay accelerating factor. Iska GPI anchor protein is impaired. And if there is no decay accelerating factor available on the RBC, what will happen to that RBC? A villain called complement will be there. It will come and grab the RBC and destroy the RBC. So that's called complement mediated lysis of the RBCs, hemolysis, complement mediated hemolysis. The vulnerability of the RBC will increase. And what is preventing that vulnerability in a normal RBC? It is the glycoprotein 1 anchor for the decay accelerating factor. CD55 is like a bade bhaiya ke saath. This beautiful girl called RBC is going out into बाजार चलता. कोई देखे तो भैया देख लेगा उसको, right? भैया देख लेगा. So complement is waiting like a villain. Then there is one more important thing is membrane inhibitor of reactive lysis, it is called as. It prevents the lysis of the RBC. It is also called MIRL protein. MIRL, membrane inhibitor of reactive lysis. It is a CD59. That also will protect the RBC membrane from being attacked by the complement protein in the plasma. यहाँ तक समझ में आ गया? गाड़ी यहाँ तक आ गया ना? काजीपेट तक अभी बलाशा जाएगा. तो क्या हो गया? When it is deficient, complement will go and attack RBC. RBC get destroyed. And what kind of destruction is this? Intravascular or extravascular? Inside blood vessel only, na? Intravascular destruction हो गया तो intravascular destruction of the RBC, do you get hemoglobinuria? Hemosideриnuria, intravascular hemolysis, you get no? Not in extravascular. So you will get hemoglobinuria. अभी डाउट क्या है? Why night? रात को क्या होता है? रात को क्या होता है बोले तो in the night we will have a decreased breath rate. Respiratory rate decreases. If the respiratory rate decreases, what cannot be eliminated? If the carbon dioxide is not eliminated, what will happen to that carbon dioxide? It combines with water to form carbonic acid. Carbonic acid breaks and releases H plus ion, and that leads to the development of respiratory acidosis. pH becomes acidotic in the night. So this complement mediated lysis होने के लिए एक अच्छा माहौल बनना है. कैसे? Street light should be off, right? And it should be not a full moon day, new moon day. And in the street, no policemen, nobody should be there. That is the right time where villain attacks the heroine whose brother is not available and she came out. Right? तब क्या होता? ट्रेन छोपड़ा क्या करेगा? हेमा मालिनी को पकड़ेगा. Right? So that is what happens. So your respiratory acidosis, that acidic environment is needed for a complement mediated hemolysis. Normal pH में complement does not attack. That's the reason it happens only in the night. So understood now the story? Now how will be the urine? By the time when the person wakes up, it is red colored urine. By the time it is once more 8 o'clock, 9 o'clock, when his respiratory rate re-established, acidosis resolved, no more complement mediated lysis. That is paroxysmal nocturnal hemoglobinuria. So how do you identify this? Typically when you do laboratory assessment, CD55, CD59 will be missing. And similarly, you can do flow. How will you identify CD55, CD59? You have to do flow cytometry. Flow cytometry. Now, what are the complications of paroxysmal nocturnal hemoglobinuria? It can lead to aplastic anemia, and it can lead to acute leukemia. Right? So, to study these things is very simple, easy, and forgetting also is easy. But to treat a patient of PNH, one case when you see, you will remember all this. So we used to have a patient called Gurumurthy, who was my patient of PNH. So Gurumurthy, regularly we used to say, if a PNH patient is there, no, you will tell him, regularly once in a month, you get a complete blood picture and come and check that you are not going into that anemic phase, right? So when Gurumurthy regularly used to come, his hemoglobin sometimes is normal, sometimes low, and then we used to take care. One day when Gurumurthy came, he is having bleeding gums, fever, his WBC count low, platelet count low, in addition to RBC count low. Why this PNH patient Gurumurthy has ended up in pancytopenia? Because PNH can lead to aplastic anemia. PNH can lead to acute leukemia. These are the two complications of PNH that you need to remember. So how do you treat PNH? Eculizumab. What is the drug name, doctor? Eculizumab. What it will do? It will go. Who is the villain? Complement complex. That to terminal complement component pathway, which is called membrane attack complex, MAC, not Windows, MAC, membrane attack complex. From where to where? C5, C6, C7, C8 combine to form the late components of the complement pathway. They form membrane attack complex. So eculizumab targets the terminal complement component pathway, that is the C5. That is how you are killing the villain and saving Gurumurthy, who has PNH, from his RBCs from getting broken. Understood the story? Beautiful. Even Harridan, you read also, Harridan fails to teach like this. Be very sure about it. Right? This is a healthy RBC for you. One more quick revision to make your mind remember. So I know that you will forget. CD55, CD59 are there in a normal RBC, and there is a GPI anchor protein. So typically when there is a and the PIGA is there on the X chromosome, then there will be no hemolysis because complement cannot attack because these things are all there. But if there is any defective PIGA, then PIGA negative PNH RBC, which does not have CD55, CD59, the complement get activated, the membrane attack complex will form, and it will lead to the hemolysis. And also it will make, one more thing is there about PNH. It will make the RBC sticky, and that also lead to thrombotic tendency. So you will also find PNH is one of the conditions which can be included in the prothrombotic hypercoagulable conditions. Agreed, doctor? No. I am a compliment nowadays. To attack you very easily, vulnerably. 1 hour before told also, you will forget. Nice. Thanks for becoming my student, sir. So my subject is getting revised. I am going to be NEETPG topper. So now, doctor, what is the dash urea? Which acid urea you get in vitamin B12 deficiency? Uric acid urea. That is megaloblastic anemia causes. What is the biochemical test in urine? Which substance levels increase in vitamin B12 deficiency? Yesterday only, Saturday only we discussed. Think. Odd chain fatty acid metabolism lead to the formation of what? 3-carbon CoA. What is the 3-carbon CoA called? Propionyl CoA. Propionyl CoA become converted by the into succinyl kante mundara madhyalo. Propionyl CoA become methyl malonyl CoA. Methyl malonyl CoA is mutated into succinyl CoA. So that methyl malonyl CoA mutase has vitamin B12 as cofactor. If the vitamin B12 is not there, methyl malonyl CoA remains methyl malonyl CoA, and methyl malonyl acid enters in urine. So high methyl malonic acid urea is a feature of vitamin B12 deficiency. Sadhukunama? Tomorrow onwards I'll bring stick. Thuk. Oh, no sir. So, I mean, our human retention, to retain things is an obsessive disorder. If you don't care, it doesn't care you. It's 54,000 points. I'm asking you to remember is a very big thing I'm asking you to remember. Right? One thing if you done, doctor, after going home, just to open the notes, at least today what we read, go through the notes, because you don't get time to read the notes while I'm delivering fatafat, no? But if you don't do that, it will sit in that, I heard but I can't recall. I heard but I can't recall. That phase it will enter into. Right? So it's like a low internet speed, it will be turning, grounding. That bring out from that stage. You become 1 terabyte per second speed. Methyl, if I say vitamin B12 deficiency, before I complete only you should say methyl malonic acid urea. Then what is the substance that increases in plasma both in folate deficiency and also vitamin B12 deficiency? High levels of, yesterday I have shown you that, ammonia. Okay, that substance converts into methionine and that is being interrupted. That's the reason its levels increase. That substance which increases in folate deficiency and vitamin B12 deficiency, that substance is supposed to convert into methionine because of the methyl radical donated by vitamin B12. So which substance? Adi, notebook movie. Remember now? Yeah, Girija, you are coming out of the college and I came on the RX 100 bike. I proposed you sat on my bike. Today Sai is also, Sai Reddy is not there, otherwise he will bash me. Good. So, very good. Already our Satyendra Alluru answered it as homocysteine. Sir, don't struggle, sir. We'll make the labor happen easily. So he gave me a tocolytic, homocysteine, right? No, oxytocin. So the delivery is over. All right, no problem. So that is the story, doctor. So for you, I'm going to give you some things, right? So you have intravascular hemolysis inside the vessel. You have something which is extravascular hemolysis which occur in spleen. Right? But before, one more thing is, the complement proteins are of two kinds. Classical complement pathway, alternate complement pathway. So you need to know which comes under classical component pathway. So basically, whenever we say extravascular hemolysis, it is the classical component pathway is involved. And it has got C4 complement protein 4 that lead to opsonization of the RBC. So C4 and C3 are the part of the classical component pathway that opsonize the RBC and break it down. Then extravascular hemolysis depends on alternate complement pathway and the opsonization with C3 only, whereas intravascular require C3 and C4. So if you look at the phagocytes that you see in the spleen, they express FC and complement receptor. So that binds to the antibodies. And then this RBC, which is opsonized by a coating, sugar coating by the C3, C4, will be attacked by these macrophages which are there in the spleen. So extravascular requires C4 and extravascular only C3.
Extravascular one is via classical complement pathway, another extravascular is via alternating pathway.
So both of them are there. So okay, if that is the case, then forget about intravascular. Your spleen may macrophages attack based on the C3, C4. That's how the extravascular hemolysis occur. All right. Now, typically, if you look at paroxysmal nocturnal hemoglobinuria, what happened? The CD59, CD55 are missing, and that lead to tick over of this C3b, the opsonizing protein. And typically, when that goes to the liver and spleen, there is a hemolysis. And also in the bloodstream, there is a complement-mediated hemolysis with the C5b. Understand? So, PNH lead to hemolysis by both intravascular and also extravascular by causing this tick over of C3 to C3b. Whereas if you look at the autoimmune hemolytic anemia, only classical pathway activation occur, not the alternate. So, intravascular hemolysis is very minimal in autoimmune hemolytic anemia. Predominantly autoimmune hemolytic, you have warm antibodies, cold antibodies, autoimmune hemolytic anemia, that all predominantly occur in spleen, extravascular. Whereas paroxysmal nocturnal hemoglobin, it occurs both in intravascular and also extravascular. It involves both alternate and also complement classical pathway. That is the main difference between the two, is what you need to remember. So, doctor, what is this very important test that you use? Flow cytometry, this is called as. And what are you trying to check in this flow cytometry? CD55, 59 being absent is what you are trying to detect. Now, very favorite question of the examiner. Hereditary cytosis is there. PNH is there. Autoimmune hemolytic anemia is there. Now tell me, doctor, hereditary cytosis, where does the hemolysis predominantly occur? Spleen, extravascular, because the spherocytes are broken down, squeezing through the spleen. Then PNH, both intravascular and extravascular, because both alternate and classical complement pathway is responsible, and that alternate pathway is mainly responsible for intravascular, classical mainly responsible for extravascular. Then autoimmune hemolytic anemia, it is predominantly extravascular because only classical pathway is involved in that. A big interesting favorite MCQ of the examiner will come. Are there any antibodies involved in hereditary cytosis? It is not antibody mediated destruction, no, it is just passing through spleen. और थोड़ा मोटा है और spleen से जा रहे तो उसको it is killing it. So it is Coombs negative hemolytic anemia. Which one? Hereditary cytosis. Similarly, if you look at the PNH, there is extravascular, there is intravascular, but predominantly it is intravascular. Even this is also Coombs negative hemolytic anemia. Whereas autoimmune hemolytic anemias are all Coombs positive. And autoimmune hemolytic anemia, the autoantibodies against the RBCs are of two types. Warm, cold. Warm is of which immunoglobulin? Garam hota hai, IgG. Cold is M. Murali Bharadwaz is cool, IgM. Except when the students are forgetting what is taught yesterday. Huh? Koi baat nahi. So, what is the triad of paroxysmal nocturnal hemoglobinuria, Coombs negative hemolytic anemia, pancytopenia, and venous thrombosis, which are, it can lead to Budd-Chiari. What is Budd-Chiari? It is an occlusion of portal vein or hepatic vein. You will give perfectly wrong answer. Hepatic vein, appa. Between gut and liver, what is there? Between gut and liver, portal vein. From the liver to IVC, hepatic vein. Portal vein formed by combination of, portal vein is formed by combining of which two veins? Inferior mesenteric vein and splenic vein. Okay, right. There are, you need to become speed in thinking. Generally, you guys are much better. 5 standard deviations better than many other students that I know. Of course, I tell the same to all students. But anything in the world we can learn. Remember, maths we can learn. I teach maths to my son. I teach Java, Spring Boot, and Python coding to my developers. And I teach medicine and cardiology for you. And I teach gynecology also. How is it possible? First, you need to know that if I go logically, I will attack. And I am born to remember it, not to forget it. Simple. And which way I have to recall. Okay. And 27 years of teaching. Of course, that is also there. Don't tell me that. So, PNH, what is the triad? Coombs negative hemolytic anemia, pancytopenia, venous thrombosis, like Budd-Chiari syndrome, where hepatic vein thrombosis is there, is what you need to remember. So, doctor, tomorrow, how will you revise Girija after going home? Quickly, while having soup before starting dinner. Okay, PNH, what are the two proteins? What is the mutation I need to remember? PIGA. It is an acquired stem cell defect. Point number 2. GPY, anchor synthesis for decay accelerating factor, which is also CD55. Then CD59, which is also called MIRL, which is membrane inhibitor of reactive lysis. Hemoglobin urea only night because there is a respiratory acidosis because of the low respiratory rate. All right, I know this. And I know this. Then acute aplastic anemia, acute leukemia are the complications. Then flow cytometry that I will do to diagnose it with CD55 and CD59. And eculizumab is the one which will go and attack the terminal complement component pathway. How much time it took? 30 seconds. Very good. Very good. I like that. Then what will you remember? Triad. So what is the triad? Coombs negative and hereditary is also Coombs negative. Autoimmune hemolytic anemia is Coombs positive, and their garam is IgG. Cold is IgM. Then here what I get? Pancytopenia. Gurumurthy, who had anemia and also pancytopenia. That is the boss said. What did the boss said? Pancytopenia in a PNH means think of a plastic crisis. Then what is the question I asked to Teja? What virus led to a plastic crisis? Parvovirus. Teja did not tell. I am happy. Teja did not tell. So that's how you need. How much time? 1 minute. Only this is what is going to be asked. Right? So next time when you are getting on metro, same thing, revision. Right? So same thing you revise. By the time metro, next station, Erramanjil aa gaya, then you revised hereditary acidosis. Then next station, Khairitabad aa gaya, then you revised it. Finished. When you come, you have Amita, the sweetest in the world. You have Monica to support you. And you have Kulsum, who is in amoeba stage. You already are in mollusca stage of preparation. All right? And you have Sai, who will forget. Lawrence, who will be coming paroxysmally. So that's how we should do revision. Okay, doctor? Next comes G6pd deficiency. What are the 10 things? 1 minute. It's X-linked recessive, decrease NADPH, reduce glutathione, increase susceptibility to oxidative stress. Then what are the drugs? There's a big list of drugs that can lead to G6pd deficient patients. Oxidative stress and anemia. What are they? At least remember, sulfur drugs, anti-malarials, favobines, right? So which anti-malarial, doctor? Primarquine. If you happen to give in G6pd deficient, it leads to development of hemolysis. So patients present with, and what type of hemolysis it is? Both extravascular, intravascular hemolysis, both kind of hemolysis. And it leads to back pain, it leads to hemoglobin urea after the person has eaten the fava beans. After few days after the person has taken the sulfur drugs. So decreased G6pd activity. And blood smear shows hinge body. What is hinge body? Oxidized hemoglobin in the RBC. And if it is being eaten away, what do you get? Bites. Huh? Degmocytes. Degmocytes is Amita's favorite answer. Degmocytes. Degmocytes. I know degmocytes. We both met in Glasgow. Good. So, doctor, let us see. What is this? Hinge body. What is hinge body? Kulsum bide? Kulsum, right? So, what is hinge body? It is a oxidized hemoglobin in G6pd deficiency. And why G6pd deficiency? There is a oxidative injury to the hemoglobin because absence of reducing equivalents. And why reducing equivalents are absent in G6pd deficiency? Because G6pd, story. G6pd is a part of which cycle? Beautiful. It is also called PPP. Very good. Pentose phosphate pathway. And because of that, what is not produced? NADPH. If the NADPH is not there, glutathione cannot become reduced glutathione. And reduced glutathione, if it is not there, there is nobody to save H2O2 or superoxide radical comes and attacks the hemoglobin. Giddi katha. Eppudu cheppukuna gide untadi katha. Kai manam marchipotuttam. Hinge body, where it is, mite cell, where it is, where is the degmocyte, where is the PPP, where is the HMP. That is what you need to remember. So, doctor, once more for your memory, glucose 6-phosphate becomes 6-phosphogluconate by the action of G6pd. And that makes NADP become NADPH. And that will make the glutathione to become reduced glutathione. And that glutathione which is reduced provide the H plus ion so that H2O to become H2O. Otherwise, the H2O2 will go and attack the RBC. Right now, the same lesson, the same points will be remembered by students in Chicago, Texas, Egypt, London. Any medical student has to read this only, right? Now, comes the next intrinsic defect. Are you done? No energy? Already that signs of congestive heart failure are appearing in Girija. You want a break? We'll finish. We'll finish. Very good. So, at this speed, I think it will take another 2 days before we finish all those leukemias, lymphomas, big list is there, and drugs and all that. Right? Pyruvate kinase deficiency. What is pyruvate kinase deficiency? Autosomal recessive. And where is pyruvate kinase involved? Do you know pyruvate kinase? Glycolysis, have you heard? This is glycolysis is a cycle every medical student will know because same syllabus in 11th class also. Fadafat bolo, glucose become glucose 6-phosphate, that become fructose 6-phosphate, then that become fructose 1,6-diphosphate, then that become diacylglycerol and 1,3-DPG, and that will become ultimately become pyruvate. Pyruvate become acetyl-CoA by the action of pyruvate dehydrogenase. If the pyruvate dehydrogenase is not there, then the pyruvate will become lactic acid by anaerobic metabolism. Right now? So before pyruvate, what is that step called as? Phosphoenol pyruvate. Phosphoenol pyruvate become pyruvate by the action of so this pyruvate kinase, if it is not there, you can't metabolize glucose. If you can't metabolize glucose, that is the only thing on which gives energy for the RBC to move. So your ATP become reduced. If there is a reduced ATP, what will happen? Normally, across our cell membrane, if ions need to go out and ions need to come in, it requires a lot of money, ATP. If ATP is not there, none of those movements occur and the RBC become rigid and that lead to spleen will recognize. Acha, what is this problem in the RBC? Oh, 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 like machar, it will kill the RBC if it is having spherical shape or if it is having any hinge body inside it, it will bite it. And if it is surface is very rigid with no electrolyte movement because it can't produce ATP, it will kill like a mosquito. That's how extravascular hemolysis occurs in the spleen in pyruvate kinase deficiency. Got it? Also, 1,3-DPG cannot move forward, so that lead to more conversion of that 1,3-DPG, one of the glycolytic intermediate, into 2,3-DPG. So when that becomes 2,3-DPG, what will happen to hemoglobin? Either you marry 2,3-DPG or you marry the oxygen. If the 2,3-DPG, the beautiful secretary comes, it will divorce the wife. Right? So what happened to oxygen? It has no affinity for oxygen. So it can't bind with oxygen when the blood cell go to the lung. So that is the problem that will happen. And that lead to hemolytic anemia in the newborn. And what do you see? Blood smear, burr cells. What do you see? Burr cells in pyruvate kinase deficiency. So doctor, please remember, doctor. See, this is the RBC. Pyruvate kinase, if it is not there, sodium potassium pump is not maintained because it requires paise chahiye, coaching lena hai to paise dena babu, paise nahi hai to kya karenge? हाँ? मुरली भरद्वाज के पास आएंगे, हाँ? क्योंकि यहाँ चाय मिलेगा, सब कुछ. Kulsum, you did not pay fee, no? Today you are paying, huh? Good. Thank you. That will mean a lot for me. You know, I can buy few potatoes, huh? And little oil, and then nicely cook food, and then be able to eat so that I don't suffer from kwashiorkor disease, thanks to Kulsum, who is going to pay the fee tonight. Suresh, once Kulsum pays the fee, your salary will be paid. Eh? So that's no problem. Eh? So then what will happen? No ATP. It can't pump out the sodium potassium, and that will cause the shape to become altered, and that lead to a lot of speculations to form. Paper and badation type of RBC pani. If there is no ATP, right? So ATP is like currency. If it is not there, currency is a paper. This speculated paper is also a paper. RBC becomes like a speculated paper, which is called Burr cell, right? Burr cell, right? So that is all the story of pyruvate kinase deficiency. Glucose become glucose 6-phosphate by hexokinase. Glucose 6-phosphate become fructose 6-phosphate by glucophosphate isomerase. That become fructose 1,6-diphosphate. That become glucose glyceraldehyde 3-phosphate by the action of aldolase, right? And in the middle, what will dihydroxyacetone phosphate to glyceraldehyde 3-phosphate? That become 1,3-DPG by the action of triose phosphate isomerase. The kind of feeling we'll have to revise glycolysis. No, oh my God. All that first year medical college girlfriends you'll get to remember. All the boyfriends and girlfriends. Wow, we used to both sit under the tree and read glycolysis on the library table. They're lucky to not fall in trap with the Veerappan. Right? So, doctor, remember, 1,3-DPG, don't take a photograph of this because this is very basic thing which is there in every damn book, damn dirty book of entrance. It should be here. 1,3-DPG become 3PG become pepper. Pepper become pyruvate. That is the place where pyruvate kinase comes into picture. That become lactate. If the pyruvate, lactate, okay? So any reduced activity of pyruvate kinase causes increased 2,3 DPG to build from 1,3 DPG, which will decrease the affinity for oxygen, and that is also contributory to hemolysis. Shanti. So only next time revision mein what will you remember? All Sutti, we don't remember. All this Kachra only. Autosomal recessive, decreased ADP, extravascular hemolysis, increased 2,3 DPG, decreased affinity to oxygen, hemolytic anemia, burst cells. Finish. 30 seconds revision of each topic. Once you are able to reach that point, you are my blood. So, doctor, sickle cell anemia will finish and go home. Don't worry. Huh? Sickle cell anemia. So, what is sickle cell anemia, doctor? Point mutation. Now, tell me, Lawrence, alpha thalassemia, beta thalassemia, which one is deletion, which is point mutation? Sadhukunam kada? Huh? That is Teja. Teja. Sai Deep's Teja. Correctly answered. After Sai Deep, Teja is going to join MD. MD ain't preference? Ophthalmology. MS ophthalmology, yeah? Very good. MS, you'll have a lot of time. He will join as Chief Marketing Officer of Incus and will become a unicorn. One day you'll see us in paper like Physics Wala, Medicine Wala. They're going to build, right? Physics Wala, famous story, you know, no? He recently became unicorn. Unicorn means 1,000 million. Valuation means 8,000 crores. Valuation by teaching Newton's laws to the school children. Right? By teaching, Bacho, 5x plus 3y is equal to 2. Kitna paisa aa gaya? Even Byju's is also that all, you know. You teach maths, Newton's laws to the children, and you are the multicorn he is. Not just unicorn. It's like 15 or 20 billion. Almost he is 1,60,000 crores is the value of the Baiju. You can run Sri Lankan country, you can buy with that kind of money. I'm going to do that. And Saidip Teja agreed. We have sir, no problem. I'll tell every student. We have some very good, nice online students like Satyendra, who is going to make me a unicorn, like Physics Wala, Medicine Wala. So, doctor, sickle cell anemia is a point mutation. Beta thalassemia is a point mutation, whereas alpha thalassemia is a deletion. That's what you need to remember. So, it is a point mutation, single amino acid, and what is replaced by what? Glutamic acid replaced by valine. How will you remember? Which is replaced by what? Valine by glutamic or glutamic by valine? GVK mol. So glutamine by valine. Then it causes both extravascular and intravascular. That means both the spleen is enlarged and affected, and also inside the cell when sickling occurs. What leads to sickling? Many times we discuss this. What is that? Low oxygen, high altitude, acidosis. So give hydrate well, antibiotics, hydroxyurea. Why do you give hydroxyurea? Hydroxyurea increases hemoglobin F levels. Hemoglobin F is alpha 2, gamma 2. Sickle problem is there in the beta chain. So that is the reason you don't, what you are defective, you don't, if it is not there. So alpha to beta 2 mein beta chain mein problem hai sickle cell anemia. So how will you overcome that? By increasing HbF, which doesn't have beta. Understand? So if people are asking, no, Kulsum, kaise chal raha hai padhai, kaise chal raha hai padhai? मैं तो USMLE को जा रहा हूँ ना, बोलो, वो पूछना बंद कर देता, right? Because USMLE is like alpha to gamma 2. It has nothing to do with the फालतू एंट्रेंस है नीट पीजी कौन प्रिपेयर होता है भाई, मैं तो अमेरिका जा रहा हूँ, टेक्सास को जा रहा हूँ. That is what you tell, they stop asking questions. So that's what you do by giving hydroxyurea. And typically the deoxygenated sickle hemoglobin will polymerize, leading to anemia, and that lead to certain crisis. One is called vaso-occlusive crisis. It will go to the vessels going to the penis, leading to priapism. It will go to the vessels going to the fingers, leading to painful vaso-occlusive crisis. Then newborns will be asymptomatic because they have high fetal hemoglobin. In MBBS days, no problem, because we are fetal hemoglobin, we don't know what defects that our beta chain is carrying. So we are very happy. The moment entrance has to be written, that became HbF into HbA. बीटा आ गया, बीटा को समझ में आ गया कि मेरे थैलेसीमिया है, मुझे सिकल भी है, पूरा बीटा screwed up, and that time you will start suffering, right? So best is go back to medical college and join in first year. Then you are once more becoming HbF. That is how you need to remember, okay? Then crescent-shaped RBCs, crew cut on the skull X-ray, just like thalassemia, because of the extramedullary hematopoiesis is what you need to remember. So remember, doctor, that the GAG trinucleotide is changed into GTG. GAG became GTG. Glutamate became valine. अभी समझ में आ गया सीट क्यों नहीं आता? सब लोग क्या पढ़ेगा? Glutamine replaced by valine. Only Kulsum knows it is the GAG became GTG. Tomorrow entrance he won't give glutamate became valine. It will ask, is it GAG become GTG or AAG became GTG or AAG became TCT? He will ask that kind of questions. Understand? So isko point mutation kai ko bolte bete? Kulsum GAG में ये को GTG में T ने replace कर दिया. That is the reason that is called point mutation of single nucleotide. Now, what are the complications of sickle cell anemia? It can lead to a aplastic crisis. And once more, Saideep Teja's parvovirus can cause aplastic crisis. Then autosplenectomy में Howell-Jolly bodies can be there. What is Howell-Jolly body and differ from hinge body? In Howell-Jolly body, you remember, hinge body is there on one side, and here it is perinuclear is tickling is your Howell-Jolly body. Then there is increased risk of the moment your spleen is not there, no? If your spleen is not there, your terminal complement component pathway will not be available, because all these terminal components of the complement pathway are produced in the spleen. Once there is an autosplenectomy, spleen will destroy by itself if there is a sickle cell anemia, right? Why? Because all these sickle cells will lead to vaso-occlusion of the splenic vessel, decrease the blood flow to the spleen, spleen gaya, mar gaya. Spleen will be automatically by itself is gone. In the spleen, terminal components of the complement pathway are produced, and they are required for protection against capsulated organisms like Streptococcus pneumoniae, meningococci. They're all what? Capsulated organisms. To protect our human beings from them, you require terminal complement components. To create those terminal complement components, you require spleen, and the spleen is gone, complement is gone. But what came? capsulated organism infections came. That's the reason Streptococcus pneumoniae like capsulated organism infections are very high in the people who are having sickle cell anemia. So that is the reason if you discovered a sickle cell anemia patient, what will you give him? Anti-pneumococcal, anti-meningococcal vaccines पहले ही दे देना ताकि उनका spleen उड़ गए तो भी they will survive. Now that lead to splenic infarct. Sequestration crisis it is called. There can be splenic infarct and sequestration crisis. One crisis is what? Aplastic crisis. Other is sequestration crisis. Right? Where all these RBCs have gone into spleen and captured by the spleen. That's called, and also they lead to splenic infarct and get sequestered in the spleen. Sequestration crisis. Then salmonella lead to osteomyelitis characteristically in the people who are having sickle cell anemia. Then vaso-occlusive crisis, very painful. So typically what do they have in vaso-occlusive crisis? Number one, dactylitis. Finger inflammation painfully is called dactylitis. They will have priapism because that is highly viscous blood with all that sickle-shaped RBCs will go to the penile blood flow and occlude that. And that lead to painful priapism, right? Because erection is because of increased blood flow into corpus cavernosum. But when the blood goes into corpus cavernosum, after the act of ejaculation is over, it need to come out. But here, what क्या हो गया? पूरा freeze हो गया, like ice cubes. So there is no way that blood can come out of the bulbous cavernosus, and the penis remains in erected state. So priapism is seen in vaso-occlusive crisis. Similarly, they will develop acute chest pain, acute chest syndrome. One more example of vaso-occlusive crisis, right? And they develop respiratory distress. Obviously, your pulmonary vasoconstriction will occur and lead to development of respiratory distress. And similarly, new infiltrate appear in the chest X-ray. And it is the common cause, this acute chest syndrome is the common cause of death. And one of the causes of avascular necrosis is sickle cell anemia. What are the other causes? Corticosteroids, Gaucher's disease. We told now one list of causes for avascular necrosis of, where did we study that? Musculoskeletal system. Old booklet. Huh? So then, stroke. The same occlusion can go to the brain and occlude the blood vessels in the brain, and stroke will occur. And it can involve the kidney. So in the kidney, what are the two components of the kidney, doctor? Kidney has a cortex, kidney has a medulla. So typically the blood will be very sluggishly flowing in the medulla. So that is the reason whenever the blood is flowing sluggishly and the oxygen concentration is relatively lower in medulla, that lead to sickling to occur and cause the acute papillary necrosis. That the papillae will be there, no? The minor calyces, major calyces, papillae, right? That papillary necrosis, one of the causes is sickle cell anemia, is what you need to remember. So typically whenever there is a renal papillary necrosis, how does it clinically present? That lead to development of hematuria. Second, papillae is the location where all your renal tubules are there. Renal tubules are required for you to concentrate the urine because water reabsorption occur there, no? So that is the reason what will happen. So whenever we are dehydrated, we produce a concentrated urine. Whenever we are overhydrated, we produce a dilute urine. Those changes in specific gravity of the urine occur, no? They don't occur. That's called isostenuria. So isostenuria and hematuria are the manifestations of the renal papillary necrosis which occur in sickle cell anemia. is what you need to remember. Then if you do hemoglobin electrophoresis, what do you see, doctor? High hemoglobin S, high hemoglobin F, and decreased hemoglobin A. And how do you treat? Hydroxyurea. That will increase the HbF and hydrate the patient well. Treat his infection with antibiotics. Give him sufficient oxygen the moment he walks into the ward, because hypoxia, dehydration, acidosis, they are all the precipitating factors. That is called complications of sickle cell anemia. Now let us look into it. So what is this you are seeing, doctor? Acute papillary necrosis. This is another example of, these are all the scars formed by acute papillary necrosis. Now one more favorite MCQ of the examiner, anyway we will discuss once more, is what are the 4 causes of acute papillary necrosis? Most important cause is diabetic nephropathy. Number 2, analgesic nephropathy. If you are taking NSAIDs, everything. 3rd, sickle cell anemia. 4th, acute pyelonephritis. Diabetic nephropathy, analgesic nephropathy, sickle cell, acute pyelonephritis. Favorite MCQ. You go to INICET, PNICET, anywhere, same question will be asked. So examiner has some expectations, doctor. NEETPG is like Pelichupulu, right? So, can you sing a song? Can you walk and show me? Can you dance with me? Will you come into another room? We will both talk. All this is NEETPG examiner is asking. Whereas, how are you going to the exam? But what's your name? Girija. Huh? Can you look at me, Girija? Yes. NEETPG examiner will be stunned. Oh my God. I expected when Girija coming to Pelichupulu to know about acute pyelonephritis, diabetic nephropathy, sickle cell anemia, acute, what else? Analgesic nephropathy. Right? Then Pelikoduku, what he will say? So I will run away. By the way, where is the father material? Em coaching ichna 4 causes of papillary necrosis also your daughter doesn't know. How will I marry her? So you should remember diabetic nephropathy, analgesic nephropathy, sickle cell anemia, acute pyelonephritis. Every time the word papillary, immediately you need to vomit this out. Then your friend will say, no, I am talking about the papillary carcinoma of the thyroid, not this. It's okay. Papillary thyroid carcinoma, is it focal, multifocal? Does it go to lymph node or hematogenous spread? You should have another 10 points about papillary necrosis. Anything, anywhere you are touched, you need to, you're a touch screen NEETPG aspirant. Please reach that point. So, doctor, next. What is this you are seeing? Dactylitis, swollen fingers is what you are able to see. It's called hand-foot syndrome. Then what is this you are seeing? Avascular necrosis, for you to remember. Other causes of avascular necrosis I am not going to ask, but you need to remember corticosteroids, Gaucher's disease, then sickle cell anemia. Many other causes are there. Then what is this? Dactylitis is what you need to remember. 1:30 we will finish and go. 2 more points. Have energy. What is that? What is that? Only with this point. All right. But before that, quick recall and recap of sickle cell anemia. 10 points. Fadafat. Sorry. Okay. Panye. You ain't చూపించకుండా చెప్పు. అదేం చూడకుండా చెప్పు.
Point mutation in BT.
Point, your professor Amita, point mutation. Glutamic acid to valine. GAG to GT? GTG. Very good. ఇంకేం గుర్తొస్తాయి చెప్పండి. Low oxygen, high altitude acidosis. Then. Decreased adult hemoglobin A. Then what is increased? Right. Then what else? Sickle cell? Crescent shaped. वो तो सिकल का ही रहता ना जी. Then auric. Papillary necrosis of the kidney. Then how many crises do you know? Aplastic crisis, vaso-occlusive crisis, sequestration crisis. And who causes aplastic crisis? Parvovirus. You will remember Saideep Teja, every time Parvo comes. Then every time degmocytes come, we have Her Royal Highness Amita, the Princess Amita is there. Then what else? Hydroxyurea is used for treatment. What else? Hydration is required to be given. Anything else we forgot?
So HbA is highly reduced and HbF and HbS are reduced.
Very good, very good. Crew cut also can occur. It is both extra and intravascular hemolysis.
There are pulmonary
And what are the four causes of papillary necrosis? Diabetic nephropathy, analytic nephropathy, sickle cell anemia, and acute pyelonephritis. Power of revision, it is called as. More than reading, more the revision should be there. So last autosplenectomy and
sequestration. Hubble-Jolly bodies.
Hubble-Jolly bodies. And where do you see hinge body? Your favorite degmocyte. Before degmocyte forms G6pd deficiency. అంతే అట్లనే చేయాలి రివిజన్. అర్థమైందా? ఇప్పుడు చదువుకున్నాం, ఇప్పుడే గుర్తుంటాయి, ఎప్పుడో గుర్తుంటాయి. ఓకే, I mean, this is a basic thing, right? Now, HBC is what? Glutamate to lysine. This is glutamate to valine. That's the reason if you do electrophoresis, which will run fastest? A runs fastest. Slowest is HBC. Fastest is HBA. HB?
HbS and HbF. Yes, sir.
Then?
And then HbF.
Very good. This how we'll do. Last 2 months we'll enjoy. We'll only do this first one round ho gaya to, then next is all recall. Bhajan program. So, doctor, glutamate to lysine is HBC. And HBC lead to extravascular hemolysis only. Once more, if the HBS plus thalassemia, if it happen, will it be severe or milder? Why?
So because the HbS is more beta thalassemia.
No. You're reaching. Sickle is the abnormality in
Beta thalassemia.
beta chain. And thalassemia is the problem of decreased beta production. That's the reason, obviously, sickle will be. If the entrance exam does not ask the questions that you don't read, you don't know, like beta chain, then you will win. So you want a thalassaemic examiner to manage your sickle preparation. Right. Now, one important difference what? HBS is both intra and extra, but HBC is only extra, not intra. Very good. Then HBSC compared to HBSS, it will be milder, right? Then, because this is also the problem in the beta chain. Then, beta chain production. Beta chain production. Both are problematic in beta chain only, no? But somehow it is, the reason has a reason that the reason doesn't know. Yeah, so blood, so hemoglobin crystals will form inside the RBC. Target cells, one of the causes is HBC. Quickly, let us see them. Target आ जाओ, आ गया target. उसके अंदर crystals भी दिखाओ, वो भी दिखाया. इसलिए इसको क्या बोलना है? HBC. And what is this? Crystal. Crystal. Can you see crystal? This is the crystal. This is the crystal. And also you are able to see target. Srimad Rama Govindo Har. So, Bhaktulara, Repu Malla, Poddunne Alayam open cheyabadunu. So please do come. So thank you very much to SMH. So one of the students said, "Sir, I am a radiologist because of you only." Wow, what a nice thing, no? God bless you. I wish you fame reaches to all the students preparing for NEETPG. If it reaches all students preparing for NEETPG, already it is fame. It's a flame. So the whole joy is in spending this wonderful 2 to 3 hours. What else this life is needed? What do you say, Lawrence? Lawrence company itself gives that pleasantness into this tumultuous, violent life of Dr. Murali Bharadwaz. We'll once more meet tomorrow. Thank you.